tuberculosis or TB, the causative agent of tuberculosis is a bacteria called Mycobacterium tuberculosis. This is an acid-fast bacteria. What does that mean? When you add acid during the staining process and then add alcohol, the bacteria will hold on to the acid. So this is why you call it an acid-fast bacteria. Therefore, we do not use the H&E stain. Instead, we use a different stain called, this is the name of it, Ziehl-Neelsen stain. This is the type of stain we use to stain tuberculosis bacteria. And on this stain, we will see, so this will be a bluish background. And on it you will see bright red rods. You will see bright red rod shaped bacteria. This is bright red. You can see it here. If you look carefully, you can see the bacteria. This image is not clear. It's of low quality. You can see it all over. Ziehl-Neelsen stain. Why? It's an acid-fast bacteria. Next, we'll talk about the shape of the bacteria, the morphology of this bacteria. So I'm not going to use red or blue. Instead, I'm going to use purple. It has a very thick waxy layer, and this waxy layer is very important for its survival. So I'm going to open the waxy layer up now. If you cut open a piece, you will see the layer like this, a thick layer like this, and inside you will have the cellular structures. And can you tell me, does a bacteria have a nucleus? No. These are prokaryotic organisms, so they have circular DNA. Now, what's important about this bacteria and this waxy outer shell is it is made up of mycolic acid. Waxy cell wall made up of mycolic acid. This is what makes it acid fast. And this is important. This bacteria are strict aerobes. What does that mean? These bacteria love oxygen. They will go to areas of the body where there is a high concentration of oxygen, high partial pressure of oxygen. And when you take the lungs, it is always going to be the upper lobe. It will be the right upper lobe which has the highest concentration of oxygen. So these bacteria will spread to the upper lobes, especially the apex. Now, how do these bacteria spread to a person? So we'll draw a person. This is airborne. This is airborne transmission. The bacteria are airborne. They will come, go to the lungs, let me draw a bigger lung because I will be drawing more on that. So let me use blue. Here's the bronchi. My focus will be on the right lung because the most common site is going to be the right apex. Now, this. Okay, I need to divide the 3 branches. There's going to be the branch to the upper lobe, middle lobe, and the lower lobe. There's 2 branches here, superior lobe, inferior lobe. Now, the TB bacteria will come, it's airborne, it will transmit from a person to another person. It will come, travel to the apex of the lung and enter alveolar space. These will enter the alveolar space. Now, what is there in the alveoli? There are macrophages. They will come, engulf the TB bacteria. Now, the bacteria is found engulfed in the macrophage. So, this is going to be a vacuole, and you find the TB bacteria inside this. So what happens is, the TB bacteria will produce some substances, some proteins, which prevent lysosomes coming and binding. Now you know, these lysosomes, their function is to destroy what is phagocytosed. What is taken in, which is harmful, are going to be destroyed by these. So these proteins will inhibit this. This is one mechanism. There is another mechanism in which, let me check. It inhibits, give me a second. It inhibits a receptor called NRAMP1. Inhibit NRAMP1, natural resistance associated macrophage protein 1. So it inhibits that, which will stop the binding of the lysosome with this. What happens then? These TB are found in the macrophages and they will multiply. They will divide. So here's the NRAMP1, and then they will destroy the vacuole that they are in. They will destroy the cell that they are in and spread. So we need to contain this. This is an alveolar macrophage. So they will come out. They can enter into lymph nodes or they can spread along the airway. What I'm talking about right now is how the bacteria will establish its infection in the body. So this first stage is called primary TB. Primary TB. And most patients, it's asymptomatic. Like you don't even know that you have it. Mostly asymptomatic. Okay, most. And some have flu-like symptoms. So this is going to progress till 3 weeks. when cell-mediated immunity comes. So what does that mean? Right now, we get cells coming, producing antibodies, trying to destroy this infection. So what happens then? TB will resist. TB will not let it be destroyed. So TB will resist. It will produce substances. Let me draw more TB. These are the white blood cells. It will produce substances. And in the middle, what happens is there is going to be a soup of destruction. Now, these will wall off the infection. The white blood cells will wall off the infection like this. So now we have the TB bacteria, we have the soup of destruction, that is all the cytokines, all the substances the TB will produce to prevent its destruction, everything, and it will form a structure called a gone focus. Now, some of this bacteria may leak out and enter into the lymphatics. Like I said, it can either enter lymphatics or spread through airway. So they can leak out and enter into the lymphatics and go to a lymph node. This is a lymph node, and the same process, the same situation will happen there. So the lymph node is basically filled with this whole structure, as you can see here. Or it can go along the airways to another site. It's always going to be in the upper region. It will be in the top region. It can go to another area and establish a gone focus there. Now, what is the type of necrosis that has happened here? It's caseous necrosis. Oh, here's the image. Here's the center of necrosis. You see the fighting organisms here. This is an epithelioid cell. It's an accumulation of white blood cells to form a larger type of cell to help fight off this infection. You learn this in respiratory pathology. And you can see these purple dots are the macrophages and the white blood cells. So this is the center of necrosis. Next, this is called primary lymphadenitis. You can see this has spread to the hilar. We can call it hilar lymph nodes. What does that mean? Yeah. Here's the gone focus. Through lymph, it has come to the associated lymph node. And this is called together a gone complex. These two together are called a gone complex. Now, for most people, for most healthy people, that is the end of it. These people will not progress to the secondary stage. What does that mean? I need a empty page here. Sorry, what just happened? Yeah, sorry. Now, for most people, this is the end of it. They will not progress into the next stage. But in some people with old age and with diseases like AIDS, so when their immunity decreases with age or with AIDS, you will get a secondary reactivation of TB. What does that mean? So these bacteria will reactivate. Now in this state, they will remain dormant for years. Remember, it's not an easy bacteria to get rid of. Some people, it can be gotten rid of, but in most, they will remain dormant for years. Now, when the immunity goes down, what happens here? I'll take this same diagram so that I can help you understand. The actively participating white blood cells have decreased. So now the control, what stops it from growth, is inhibited. And now these will reactivate. In the sense, they get to leave their place and enter into the, they will travel along either airways or through lymphatics. And there's another way which I didn't talk here because in primary we do not get it. They can also travel through blood. So let's draw that. They can spread like this. This is the airway. This is through blood. And this is lymph. 3 ways. What happens when the bacteria spreads through the airway? You will get the infection traveling down. You will get the same gone foci, or the bacteria will travel down. See, it loves oxygen. That's why I'm still drawing it in the upper lobes. And what happened here, which allowed it to spread? It has destroyed the wall. It has destroyed this wall which trapped it. So it will form a cavity. It breaks through the wall, forms a cavity and passes along. Next, it can go through lymph and especially to the regional lymph nodes. That is, in areas such as, give me a second, the larynx, the pharynx, all those areas will have, endobronchial, endotracheal and laryngeal. This is for lymphatic spread. Let me change the color. So what does that mean? It can spread through the lymph this way. And what happens when it goes to a certain location? It will destroy that area. There's going to be caseous necrosis and destruction of the associated areas. Finally, if it goes through blood, it is a condition called miliary TB. Miliary TB. The reason for that is the shape in which these lesions occur. Look at this. This shape is what gives it the name. These are granulomas which are formed in the spleen. This is the spleen, a major organ involved in fighting off infections, and you can see the yellow cavities. So miliary TB, we need to talk about that in detail. Now these patients will have systemic spread. What does that mean? There's going to be bacteremia which can go, this is called systemic TB, through blood. So it can go to all organs, all sorts of organs. First, we'll talk about the kidneys, because kidneys have high oxygen concentrations. And these patients will have sterile pyuria. That means there's no organisms, but there's going to be white blood cells in the urine. Next, it can go to the brain, meninges, and it can cause meningitis, inflammation of the meninges. And a very common location that these love to go to are the lumbar vertebrae. It causes a condition called POTS disease, P-O-T-T disease. Next, can go to the adrenal glands and cause Addison's disease. You don't need to know these, just that it can go to basically any organ. It can go to the liver, cause hepatitis. This condition over here is called lymphadenitis. That is a disease of the lymph nodes. And it can go to bones and joints. So basically what I'm trying to say is, if there is secondary TB, it can spread in 3 ways. One, through the airway, next through lymph, or it can be miliary TB, which is systemic TB that can spread to almost any organ in the body. This is oxygen rich region, so it loves to go there. See, you can see the cavities formed. These are cavities formed that allows it to spread. This is infectious meningitis. You can see the destruction. It goes, destroys that area. And this is in the intestines. This is usually perpendicular because of the way the lymph vessels travel. The lymph nodes are here. From lymph node to lymph node, it can spread. It's not just this way. It can go to many locations, even through lymph. Because of the way the lymph nodes are occurring, you get this type of ulcer. It's across. It's a transverse ulcer. And the bones, you can see here. This is a bone, the joint. You can see the kidney ulcers. And this is a regional lymph node affected. It has gone this region. It's all TB. And you can see the caseous necrosis in the spinal cord. See, these are cavities formed. They're all cavities formed. I need to add this word. You can see there is going to be contraction because after this forms, the final stage of it will be fibrosis. When that happens, it forms a scar, and as you know, scars contract. they come inwards. So even in the intestine, there can be stenosis. So if this is the intestine, because of the scar formation, there can be stenosis like this. Next, we will talk about the diagnosis of TB. So the first thing we do with patients of TB are do a PPD test, suspected patients. So these patients will come with symptoms of, let me write the symptoms: fever, night sweats, weight loss symptoms, and hemoptysis. So what do? We take the sputum and send for testing, for acid fast testing. Or you can do a bronchoalveolar lavage and again send for testing. This is to see if there is active TB. Next, we can do a test called a PPD test, Purified Protein Derivative Test, Tuberculin test, or Mantoux test. So what they do is, they inject components of the bacteria which can elicit a hypersensitivity reaction in our body. Then what they do is, they will mark the diameter and they will measure it. So if the diameter is a large area, it depends. The diameter, the value they take depends from country to country. It is a positive test. This is called a positive test. That means this patient was exposed to TB at some point, and it will come positive in over 2 billion people in the world. Next, you can do a test called interferon gamma release assay. I will come back to the PPD, so leave some space there. Interferon gamma release assay, IGRA test, where you take, it's a blood test, and it is unlikely, this is important, unlikely to be positive from BCG. Now BCG vaccine is a vaccine given to children, and what it does is, it prevents disseminated TB. That is the main function of this. So you do these tests, especially the PPD test, and next, to confirm the diagnosis, you do a chest X-ray. So if the chest X-ray is positive, what do you mean by positive? You will see thick cavities or thick regions of fibrosis, especially in the apex or the hilum, because the lymph nodes are involved in the hilum. So if you see very thick fibrosis like contour, so if you see thick white color dots in the chest X-ray, that is a positive test for TB. Then you need to start treatment. So treatment. For latent TB, what is latent TB? TB which is in the body and not leaving. So the dormant stage, you can give these patients a single drug for a long time. The drug of choice is isoniazid. Isoniazid. For an active TB infection, it's a drug combination. So what are the drugs we give? It's also for a long time, but the drugs we give are isoniazid, rifampin, ethambutol, pyrazinamide. So within weeks, these patients are non-infectious. Then we have the troublesome bacteria, the drug-resistant strains. So for pathology, we do not need to know this, but I'm just adding it to complete the discussion. MDR TB, multi-drug resistant TB, or extremely drug resistant TB. The extremely is written as X, extremely drug resistant TB. So for XDR patients, we give pretonamide, zinc solid, bedaquiline. So these drugs in combination are given to these patients. That is it for TB.